what are all my options that are available to me? And again, we're dealing with, at this point, a disease that is not curable. It's manageable, but not curable. So actually doing nothing and observing is an option that should be discussed, even if it's not the best option. I think, again, my approach in my practice is to try to put all the options on the table, even the ones that might not be the best options, and then take off the ones that are truly not in someone's best interest. But certainly in somebody who has indolent disease that isn't causing a lot of symptoms, even though it may be appropriate to use chemotherapy or other treatments, if they're feeling fine, it may also be appropriate just to wait and see how the story develops. There are often other treatments available that should be discussed, and so asking that question of what are all of my options, I think, is important. The hormonal therapies are used by some of the colleagues you've already interviewed, so the radiation oncologist and the urologist as well. Chemotherapy is really where the medical oncologist is involved exclusively in the treatment. When I get approached, when I approach a patient for chemotherapy, I think the word chemotherapy elicits strong reactions, and that's where I wanted to make it clear that chemotherapy just means that we're using drugs aimed at the cancer, and there are many different chemotherapy agents out there. I think the first question that comes up quite often is related to the side effects of what people perceive chemotherapy to be. So, when people hear chemotherapy, many people think about losing their hair and about vomiting and feeling generally unwell with side effects. And in reality, there are many chemotherapy agents that are used to treat cancer in general, and they range from pills that have very few side effects to intravenous therapies, some of which do have very strong side effects. And so in the case of prostate cancer, I often find myself, as the first question that I have to answer, is that the chemotherapy agents we use in prostate cancer specifically are generally very well tolerated. They don't usually cause nausea and vomiting to any major extent, and they may cause some hair loss, but usually not complete hair loss. So some chemotherapy drugs can cause a lot of nausea, although we have such good anti-nausea medications now that people rarely have severe nausea and vomiting while they're on treatment. But actually the chemotherapy we use with prostate cancer doesn't usually cause a lot of nausea or vomiting. So patients rarely need to take extra medications to manage nausea when they're on this treatment. One other side effect that people who are going to start docetaxel treatment need to be aware of is that docetaxel can actually irritate the nerves that go to your fingers and toes. The fancy term for this is peripheral neuropathy. What it feels like, patients describe to me sometimes the feeling like, when your hands fall asleep, that sort of nummy, tingly feeling. It usually doesn't affect your fine motor skills, so you're not dropping things and you can do up buttons and so on. But it's a nuisance. It feels kind of numb and you shake your hands and carry on. Some people describe it on the feet. It's usually sort of the bottoms of the feet and the tips of your fingers. People describe it as like walking with several pairs of socks on. It's just a bit more numb than normal. And that's a cumulative side effect. So it means, when I give you the first or second treatment, you're not likely to have it. But by treatment 7, 8, 9, 10, it's more likely to be there. And that usually gets better after you're done the treatment, although I have some patients who, even a year out after their chemotherapy, still have a bit of numbness left behind. And I would say if we stop the treatment early, like before the 10 cycles, this is one of the more common reasons why we stop, is because they're starting to get uncomfortable with this. One of the side effects of chemotherapies in general is that it can affect your immune system. And I think a lot of my patients have an awareness of this when they come to me already. And so one of the questions I'm often asked is, should I be avoiding exposure to other people or going out, to parties, for example, because of the risk of infection when you're on chemotherapy? And so I spend, again, quite a bit of time counseling my patients that the risk of infection is the same no matter what they do at the end of the day. And so the goal of treatments such as chemotherapy are to to allow you to live your life, not to limit the way you live your life. So often patients, when they become aware of the risk of infection while on chemotherapy, will ask me if there are things they shouldn't be doing. Should they be avoiding large groups? Should they be wearing a mask? And the answer to both of those questions is no. But I sometimes say that you shouldn't put yourself into a situation where you're clearly exposing yourself to a risk of infection. So, for example, I wouldn't go kissing somebody who is clearly fighting an infection of some sort. Or I say you shouldn't maybe spend time sitting in the hot tub at the YMCA when you're in the middle of chemotherapy, because again, there are a lot more bacteria in those places. But as far as living a normal life and doing things you normally do otherwise, it's all acceptable. So usually when you're coming in for chemotherapy, before that even happens, the cancer agency has education sessions that you would go to, and you would get educated on chemotherapy in general and what the most common side effects are and how to manage them. Your doctor will give you a prescription for any medications that you need to take to manage any of those side effects, and you would be advised to fill that prescription before your first visit, and so you need to bring all those medications with you. And when you check in for your chemotherapy, the nurse would advise you on when to take which medication. So, for example, if there's a medication to avoid allergic reactions to a treatment, you would be told to take that before the treatment starts. So when we use chemotherapy, the main chemotherapy we use for prostate cancer is a medication called docetaxel, and that's given as an intravenous every 3 weeks. And so it's done as an outpatient treatment. If somebody were having the treatment, they would come in on the first day for a few hours to get the treatment, and then they go home. And they don't come back again until 3 weeks later, and the treatment is done again. And we usually repeat that for a maximum of 10 treatments. So when we give chemotherapy for prostate cancer, it's usually a maximum of 30 weeks of treatment.